Kelly. You all are so good that we actually have a good bit of time for some discussion, either comments on what you heard in these presentations and that feedback, or if you have some things that you wanted to raise yourselves. So, thanks. Steve, do you want to start?
I just want to make an observation that I find fascinating, which is that the Roundtable had a workshop in the spring on modeling and its role in population health. And I was on the planning committee for that one, and I came away from that roundtable with the same observation that I'm having now. We went to that workshop thinking we were going to be talking about the technical methodologic issues in modeling, agent-based modeling, simulation modeling, Markov chains, and so forth, and ended up talking about the community and the need for stakeholder engagement. It was taken, the technical details were taken over by the discussion of community and stakeholder, and I think many people have commented today that we came expecting a discussion about data sets and linking data sets and statistics and so forth, and once again we see the dominance of community and stakeholder engagement as being paramount. I think it's interesting.
I think we heard a lot about having a human face on this, the things that people resonate with to make them meaningful and impactful, so that's great. Others want to comment on? Oh, okay, good. So George, thanks.
Maybe what we didn't hear enough about, and it's probably because of the selection of people who are in the room, is word from a business community, from making a business case and what kind of cost data or insistence on data that would satisfy not only cost benefit analysis, but industry, profit making, economic sustainability, those kinds of things. And again, maybe community doesn't care as much about that as you know, what's best for health. But from a business perspective, and what drives a lot of the decision making and policy needs economic viability. So I'm wondering if maybe we ought to be doing a little bit more exploration of that.
So do you want to talk a little bit about,
I know
in one of your groups you talked about we talked a little bit about ROI versus cost benefit versus capturing a lot of those social benefits that matter to people but hard to capture in finances. So good. Israel?
So I'll premise this because I come from San Francisco Department of Health, where we're both a health delivery system, a population health, and are huge researchers. And so I think that the question is I don't think for us we have a lack of measures. It depends on what we're measuring. And if we're talking about population health of all San Franciscans, how we use the lens of how we use the people's data to share back with them, and how do we engage them and bring the right partners in the table. If we're talking about our healthcare delivery system, we know we look at meaningful use and other indicators and how the population of that clinic is doing and how we can link that clinic to other resources. If we're talking about bringing partners, part of this is ownership. I think the sense of getting away from who owns the data and what do we want to achieve with the data. So if we're doing our community health assessment, we're engaging community, we're talking about what their priorities are. It's really getting the partners to agree they're going to stop doing what they're doing and do what the community wants to do in that CHIP process. That doesn't mean the hospitals stop not measuring blood pressure. That doesn't mean that there are measures. So I'm a little bit confused when we say population, maybe because I'm in population health. What are we talking about? Are we talking about research? Are we talking about how public health systems function? Are we talking about the contribution of hospitals? Are we talking about the contribution of partners? And I think if we can get a sense of what are we trying to accomplish, then we can find, I don't think that there's, at least for us, maybe because we're fortunate, a lack of data. It is really about a lack of vision in what we're trying to accomplish, and then apply the right method to the solution. And I'm not saying that would work for every jurisdiction. Again, I'm premising it from San Francisco. So I think sometimes when we mix the conversations, we can often then get caught in the confusion of the roles of each of the stakeholders.
And so I'm also hearing a little bit, we've heard a lot about activation of communities and figuring out what they want to do. But there's still a big step then to find the resources and everybody to these organizations to step up and make the investments and commitments necessary.
But I think Megan did a great example where she convened the group and brought the right partners to the table, and they started looking deeper at their data. She didn't fund them completely, and I think it depends on, are you looking at it from a public health function versus an academic lens? So you have to ask the right question.
Good. Yes, Mary.
In listening to this, it reminds me that we're talking about a lot of new ways for people to work together, and we've had the experience through both a TCE and a CDC-funded set of leadership fellowships where people are working in a multi-sectoral way, so that you've got teams that cut across different sectors, and they have to learn together. They have to learn how to work together, but in looking at their language and their data, they're all really focused on making change happen in and with community, coming at it from different perspectives. And I think what we're hearing, from everybody is that depending on the lens, and I think the challenge is to teach some new leadership skills so that you can learn how to bring those different perspectives together. You would pose questions differently, you would collect different data, or you would merge different data sets and have a cross-sector way of analyzing it that's quite different. And I think we have to remember that that's not how many of us were trained in public health or medicine or whatever our discipline is. And so much of the work now is multidisciplinary that I think it elevates a whole nother level of this discussion that we have to be conscious of. It's not either or, it's both and.
David.
So I'm wondering about this tension between local purpose and responsiveness to sort of local needs and energies, and the need for some standardization or synergy. And you lose something, of course, when you go towards more standardization, but I'm not sure that it's the most efficient way for every place to create their own wheel. So but I tend to be a little more on the centralizing end of the scale anyway. So, but I think there may still be some opportunities for thinking about a set, not necessarily a single, but a set of approaches that others can learn from without having to invent the wheel every time.
Yeah, Rajiv?
So two things. Just that I think that this tension between sort of ground up versus top down, however you want to call it, it's there. It's going to remain there, and there's purpose in both. So I don't think that they can, I think, exist with a sort of a healthy tension and inform each other. The centralizing measures may be really commonly used local measures. The local measures may be innovation measures that inform the sort of the central core set. So I think that's an easy tension to accept. The other one that was, I think, raised on a table, I don't know exactly which table, this sort of the disconnect or the disconnect even between the public health world and the healthcare world. In the healthcare world, where a lot of data exists, rich health information, and then there's outside the HIPAA firewalls, there's the community level data, where maybe they're self-rated or behavioral health outcomes, or what are we doing to connect those two systems of data? And I guess my one possibility is starting to ask questions about social determinants on the HIPAA side of the firewall, on the healthcare side of the firewall, and and have, just like we have burdens of disease for this and that, we can have burdens of disease from hunger, from food insecurity, from housing instability. But it requires, I think, the healthcare system to collect the data, but not be the actor, to be the witness, to be the data producer, and then somebody else to basically be carrying that information across to the other sectors. That's one, I think, sort of one. But connecting these two worlds, we're not leveraging, I think, the power of the healthcare system and all that the health outcomes data there is, and there's a historic tension between health care and public health, and frankly, sort of a lack of effective working together that I think is a hindrance to that.
Yeah, maybe I think many of you are aware that there was a recent IOM report on incorporating social determinants, specific social metrics into the electronic health records that might enable that. Rajiv, I figured you'd have something to say about that.
Yes, I do. And I think, okay, it's a milestone report. This report proposed a set of behavioral and, I guess, social measures. And so at a high level, I'd interpret it a couple of ways. What they were doing was, in part, standardizing the doctor's social history. That doctor's social history was largely behavioral. So it's smoking, exercise, et cetera. Where it's being, and then the other major part of what was proposed was standardizing identity questions. I don't think that gets to the scope of the social determinants. The location of data collection in the EMR is not a place for systematic data collection. The doctors may ask the questions or not. They may populate it or not. But mostly they're not, I think, the questions that are getting at actionable determinants.
So would you like to tell us what some of those are?
Would I like to tell you? Sure. I mean, we have systems for, so there are, so food security, it was a question in there. That's an example of the type of question that's in there that's actionable. We have a system for food security. But if that question was asked instead of at the EMR level, at a plan level, at enrollment, every member in a plan was asked a level of food insecurity. You would be able to very easily then prospectively look at the differential outcomes and costs at different levels of food security and have an economic argument for making, to the public sector, for making investments in food systems. And I think the same thing could be said for social isolation, or housing instability, or difficulty paying the bills, or other questions.
Right. And then making, at an individual level, a lot of those linkages as well.
Right.
So it can exist on multiple levels.
So the attributable burden of disease to unmet needs could be collected in the healthcare system and then translated out to policy argument, to people who are trying to control healthcare costs in the long run by making investments in the other systems.
Right. So do you have a comment over there?
Hi, my name is Dan Gallagher. I work for the San Diego Association of Governments, which is the regional metropolitan planning agency for San Diego County. And I just wanted to pick up on your comment of working in silos. I think in this emerging area of public health in the built environment, which I work in, I think it's really important to form partnerships. We partner closely with the County of San Diego Health and Human Services Agency. They provide health data. SANDAG provides and aggregates a lot of mobility built environment data. So we share that data, we work together. And I think it's also really important to see that all of these disciplines really complement each other. I mean, there's been studies done where both public health, community design, and economic development all work together. I'll just give you a specific example. If you're familiar with San Diego, the Bird Rock area of La Jolla implemented traffic calming and roundabouts. And there was an economic study done after that, because what that did is it was a wide, La Jolla Boulevard was a wide arterial. And what these traffic calming measures did was they really helped to stitch the community back together. So then more people were walking, biking, which is good for public health, and they were frequenting the businesses. Study was done on sales tax receipts, which went up. So I think it's just to really see these things, as you were saying, as multi-sectoral, and how all of these disciplines really work together.
Thank you. Matt?
This may come across as just more consternation than insight, but from a conversation way over the other end of the room, it prompted me to think about our frame here, sponsored by Institute of Medicine, thinking of social determinants of health. I was trying to find the lyrics to this Paul Simon song about one man's ceiling is another man's floor. It's more like
You can sing it.
one man's determinants is another man's outcome, and so we're here talking about the social determinants of health, and I imagine that there are people in other forums around the country talking about education and thinking about health as a determinant of educational outcomes, or in economic vitality, thinking about health as a health determinant of economic vitality. And so we're in this web of means and ends, and we've selected this one end that we think trumps the other somehow, or it's just a bias that we come in with. And I think there's something about reframing to think of health as one of the components of this complex system that produces some higher level end, and whether it's individual well-being or societal or community well-being, and then it seems to me that reframes the conversation to make it health being part of the multi-stakeholder collaboration, and that it's one important dimension, but not the dimension that all of the others serve.
Well, something resonated, didn't it? Okay, great. Any final thoughts? If not, thank you. It was clear that there was some very rich discussions, lots of food for thought, and IOM staff has a big job to capture many of those and organize them as part of this workshop. So with that, I'll turn it back over to
Thanks.
Co-Chair George Ashton.
All right.